Today na the 21st day of December 2020. They get with health talk with Dr. Isatu Kakay-Diallo. And today we want to talk about oxygenation, hypertension, and stroke. We remember saying we be done they pick on the issues then day, and we've been promising we will get the doctor make it come elaborate more on that so that we will get a perfect understanding waiting na the cause and waiting can lead to such. So now the reason that one day we do the program today. Let me just give the updates. The updates for COVID-19 na salon. We not been there yesterday. So the labs them yesterday on the 20th, them be analyzed 579 tests. 579 tests and the labs they analyze. Out of that 579 tests, 12 turn out for be positive. 12 turn out for be positive. Out of the 12, now so the district then be represented. Western area urban 7, Western area rural 4, and Tonkolili 1. That not been for yesterday. Today, the 21st of December, the labs then analyze 125. We all know say that is very, very, very low. Should we say all the test results them not come inside. So now make all the test results them not come inside. Now make. So because of that, now 0 new case na salon get today. But based on waiting 125 test them all the labs then analyze and based on that. So let's see waiting tomorrow go look like. Let me see waiting tomorrow go look like. Because of the 0, just like yesterday, the cumulative confirmed positive cases still they at 2,509. 2,509. The total number of deaths, we still stand at 75 because for the past 24 hours, nobody not lost in life to COVID-19. The one in modern isolation center at 578. The cumulative recoveries, we still there at 1,856 because waiting do for the past 24 hours, nobody no recover from COVID-19. The one them were in quarantine now 186. The one them were on discharge from quarantine now 12,301. And so the numbers then look like. But make we go to a Mano River Union countries them, make we see how today be look like. Sierra Leone, we know just now, 0. Guinea, 18. Liberia, 0. Liberia is doing good. If you compare for the last few weeks, Liberia then they do very, very good in numbers. I just don't know how much then they test though. But in the numbers then for the 0, 1, 2, 3, then they do very good on that area there. Ivory Coast 28, and then they give you a total number of 46 new cases them. Now the Mano River Union countries them for today. And the cumulative death is still stand the same. Sierra Leone 75, Guinea 80, Liberia 83, and Ivory Coast 133. Then they give you a total number of 371. So now so the COVID-19 numbers then look like. For Rio de Salon, with the rise of the numbers, yes, we know so we get 0 today, but now based on 125, please take precautions. A big or the big. Do ya take precaution? Okay. Angela, I mean, that's so you can say, Triple A, thanks. You don't make me picking. Uh, don't sabi sing with national anthem. Every day, it listen. Okay. To the Pekin, we have to say thank you for sabi the national anthem through Sarah Network Radio. Eh? Okay, we go soon come with Doctor. Today, a surprise we get.
Hello, good evening, everyone, and good morning to many others. Nina Dr. Isatu Kakay-Diallo, family nurse practitioner, board certified. They work for all the one that way don't they listen to me, know me. See, I work now oncology, hematology. But today we want for can talk about certain things and where we need, and also some of the health conditions that way we can face, if we not take care of ourselves. So the topic today we want to talk about, we don't do health discussions and sorry network radio. Once in a while we can come, we talk about things where we can encounter or things that we'll need for do for prevent ourselves from, getting sick, and how we protect ourselves. So we want to talk about oxygenation, why we need oxygenation. Also want to talk about hypertension with a high blood pressure and stroke with a cerebral vascular accident or brain attack. So then three topics they had today, we want to touch on them because they're somewhat interconnected. So we feel say it makes sense for put them all on board at the same time. When a broad topic, where we say, we will continue for the deal with them, we will continue for address them and ask questions, and we will need for ask questions So the first thing we'll want for know first, what are some of the reason and also what are some of the benefits as to why you need oxygenation, to start with. So first of all, before then we'll give you any oxygen because the within the room you get about 21% of oxygen, in the room here. For letting you anything above that 21%, they can to oxygen, then they do them because they want for let you body will get enough oxygen in the blood, and also for ensure say you go breathe well without feeling very tired and things like that. And at the same time it will help for reduce stress by your heart, like the muscle then for your heart. If you don't get enough oxygen, it can make the heart they pump too quickly, too fast, and then you go get tired very easily. And some of the other things and back we can make people that need oxygenation, for example, let's say you don't do an assessment that you find out, say this person is hypoxic, meaning you don't get enough oxygen. And then also then do a blood test where they show say you arterial blood gas is then low. It can be due to acid-base balance, or some metabolic conditions, then we can do that. And also if somebody in oxygen saturation, it is below 95, then they can tell you, say the person actually gets low oxygen, in the blood, and also then therefore verify that with the arterial blood gas, we will tell you within at the oxygen level, whether or not some acidosis, or alkalosis, then or bicarb, then kind of thing, and if they go on because of some injury, some trauma can lead to this, or if you get any lung disorder, then kind of can happen. But the normal oxygen saturation, like if you recall, anytime we go to a hospital, we then can check your blood pressure, then you put something at your finger or check what's in your oxygen saturation. That number there for be 95 to 100. Anything below that, then therefore look into it further. Some people then, like let's say somebody will get lung problem, like chronic obstructive pulmonary disease, what they call COPD. Then people then they then can live with oxygen saturation for under 95, meaning 90 to 93 is okay for them. And even we then give them 2 to 3 liters of oxygen through the nasal cannula. We will try to talk a little bit more and the different ways them how they can give oxygen to person. So again, what you want to know about oxygen in our body, oxygen really now like a fundamental for we health, right? The way I would take in oxygen, I will breathe in, right? And it's very important for love get down there, for let it take care of all we metabolic needs them, and at the same time it help with the energy, and the oxidation of nutrients, now we body, and also when it can to how we body they function, how the cells then they develop, they grow, because if you not get enough oxygen, we think it end up for happen, you can that cell they become it die, so like somebody way, for example, we go get like a myocardial infarction, because due to or a stroke, which we therefore talk a little bit more about, that due to a lack of oxygenation, either because there is a blockage or either because now some form of injury and don't take place. And also then don't they link the connection like cancer with lack of oxygen, because then they say the cells then are like oxygen, the cells are not get oxygen, so they can still go ahead and grow and multiply, do the harm what they do to the body even without getting oxygen. So definitely, you not get oxygen our body, it will really affect we. And then you definitely need them for breathing, it bind with you, red blood cells, them, you need them for your brain, you need them for other tissues, them, your entire body need oxygen, because as blood they flow through, the blood they flow with nutrients, they flow with oxygen, where they going to the brain. And this again, this other slide here, so they just give you the key things and what make we really need oxygen in our body. So as you can see on the right hand side, the red blood cell will get, so first person to get oxygen from the lungs, and then it bind with the hemoglobin molecule. We then go in turn, bind with the molecules them. That way it can get rid of carbon dioxide, because just see it as you breathe in oxygen and then you get rid of carbon dioxide. But then, the oxygen need for bind with the red blood cell as well. That's why they call it hemoglobin. So hemo means blood, and then globin a protein, and then, so somebody will not can get oxygen, they can get hypoxemia. Hypoxemia meaning low oxygen in the blood, Then oxygen, sometimes, you need for aging of your human cells, it helps to relieve headaches, alleviate tiredness. If you're really tired, you not get enough oxygen, it also helps for boost your immune system, and it is support the breathing of the air where they breathe in, if you, in case of any asthma, in case of any allergies, so you really need oxygen in your system. And also, it can help for get rid of some stress or depressions. If somebody not gets enough oxygen, all NTI, it creates anxiety for them. So it can improve your performance when it comes to physical activity, about up to 25%. And then other things we can make them somebody can require oxygen therapy. Really, if the person get asthma when airway constriction and inflammation. So meaning the airway it becomes so tight, and then that's the way don't become tight. There's swelling around it, so that it can swell. So it swell up the opening instead of like you get the breathing. That not can happen with people that we can get asthma attack. So what they can do in that case, because of the inflammation, then they give them steroids. And because of the constriction, then they give them the bronchodilator. So then they dilate the bronchial smooth muscles for let them go breathing well. So you can see some people that way get asthma, the breathing is very difficult for them. And somebody back we get pneumonia, because the pneumonia when an inflammation of the lung parenchyma, due to some kind of virus or due to bacteria, the person they in need of oxygenation. So that's now other indication for which he make them would require oxygen therapy. And if somebody gets sepsis, meaning you don't get bacteria in the blood, it can cause so many different complications. When a whole topic on its own, but that again other indication for oxygenation. And sometimes some people then can get what they call ARDS, when an acute respiratory distress syndrome. Now something way very sudden, it can become very progressive, cause swelling at your lung, and also it can cause infiltrates of some way you can see, like when they do your chest X-ray and they see an infiltration, say this person gets ARDS, like there's a decreased lung compliance, meaning your lung not, inflate and deflate, effectively. And sometimes symptoms of that now, like a really a rapid onset of severe dyspnea. Dyspnea means shortness of breath, meaning you're not able to breathe well. And hypoxemia, which I mentioned, say, meaning the person get low oxygen in blood, but at the same time, this person will get ARDS, not can respond to even oxygen we then give them. So then people there then can mainly then they intubate them, meaning that they on a breathing tube. Now the machine now for breathe for them. And the COPD, which I mentioned, like it comprises of 3 different lung diseases. Them asthma, now one of them, bronchitis, now other one, and emphysema. So all these different topics, them about lung disease, then get their own symptoms. The people that can suffer from can be due to many different triggers. Them. For the person will get emphysema mainly now smoking, cigarette smoking. So it would be important, if you know a person with a smoke, that you really look at the benefits of the smoking, which I don't feel say there's much of a benefit really. There's more of a harm to you. But you can see patients, them, even though they know say they get COPD, then they're on oxygenation, they're still the smoke, but you know that for tap or talk to them, you get for continue, for they tell them, say, this is not good for you. You really need for cut down on the smoking. You really need for quit to start with, because your lung already don't damage, the elasticity now you lung in not that great. So as we done, as I don't mention about chronic obstructive pulmonary disease, we now COPD and in other indication why people then can need oxygenation, and also some cardiac related issues them can make person need oxygenation. Like if you get MI, like when a myocardial infarction, like you get a heart attack, then will require for let you get oxygenation. We come in to the hospital or the emergency room. And this is not just a pathophysiology to see really if somebody get problem with the lung. Let's say they get injured, either from an accident or then they get a pneumothorax, or like a chest trauma, any of them, and they, so you look at those things as acute lung injury. So the acute lung injury, where it happen, what can happen, the body they try to fight the problem. They realize, say, something is going on wrong here. I have to do something, right? So the first thing will happen, it will cause inflammation, meaning swelling. Inflammation means swelling to your immune response. Thereby some chemical agents them when your body, then they use them for 5 different things. They release all them different mediators they are, so for see how best and we will really counteract the effect. But in many cases, it can become successful. We body can always fight for we immune system is strong to the point that if something they go on, it can come on board and bring on the defense mechanism them, especially when you talk about your lung, when you talk about infection, we get like a cut and things like that. So all things that can happen. So where that happen, where they don't release all these different mediators them, first it increase the capillary membrane, permeability, and then it decrease the airway in diameter. We'll talk about airway diameter. Just take a look at it as a tube, where it be say it been big, air they go in and out with no problem, or blood they go in and out with no problem. But now, because of this injury, because of that swelling, it make that space they tight. So it make the space tight, so they even get enough oxygen or blood flow through that vein or artery there. So, and again, it can cause injury to your pulmonary vessels them, and also within the surrounding as well. And if this continue, what can happen, you get alveoli, them where they float around, with loss of surfactant. Surfactant now something we need, for let it really keep the lung from collapsing. So it prevent also, tension. And if that continues, it can cause the lung for like collapse. But then another thing which can happen, the person they get like a increased airway resistance, and the lung compliance they become decreased. And at the same time, it cause pulmonary meaning lung, it cause a vasoconstriction, by also having like microemboli formation. So because if they get vasoconstriction, which means like a tightness of something, so the blood not flow as it's supposed to, on a usual way somebody not get no injury, it is left some blood them behind. So with them blood that would flow, blood where they left behind, then can form a clot, like a blood clot. So that can happen at the lung, and also the person can get like hypertension, like high pressure within the lung system. All these now can lead to decreased cardiac output, meaning the heart not pump enough blood flow for send them out, because the heart get 4 chambers down, so it can go through all the cycle. But because of all this injury or what don't happen within the lungs, the output is is decreased, and at the same time, they cause like a dead space of the alveoli, and thereby it increase the breathing, like the work of somebody in breathing, and at the same time, it can cause intrapulmonary shunting, right? And eventually, what thing that will happen now, we do a blood test, you can see this person get hypoxemia, meaning low oxygen in the blood. That's not the pathophysiology as to where somebody get a lung injury, which can happen. And this now like a form of lung collapse, where they call atelectasis, meaning it can be both lungs or part of the lungs and we can collapse. If you lung collapse, really, it shows say there's a airless condition of the alveoli, where they cause, hypoventilation, meaning low, breathing, ventilation, and obstruction to the airways, can cause that, or compression. And this can be like for somebody who get a surgical procedure done, then they're at higher risk for really get atelectasis, So this is not something where, people can go for look at, if you go through a surgery, especially when you don't do a C-section, for example, some same day surgery or any major surgery, as long as you're able for, talk, they not put any restriction on you, it will be nice for like you use the incentives parameter, because with that, you use that every 6 minutes, like about 10 times in 1 hour, Now for that, then tube that within the give it in at your bedside, you just need for blow air into it and see how high, that there's the little cap in there, they measure how much air you were able to breathe in, then they can help for expand the lung as well. So then people then with atelectasis, sometimes some of the symptoms and we then can present with, now like something we're very insidious, meaning slowly, they include cough, like the sputum, then they get sputum production, they can get low grade fever, so something above 99, 0.8, there around there, or 100.2, then low grade fever there, so person can present with, and also they can experience respiratory distress. They can become very anxious, as well as because of the lack of oxygenation and the lung collapse or part of the lung collapse, and also some of the things that we will really encourage the person for do even if you're not a loved one to the healthcare provider. If you really visit your loved one, then don't get incentives parameter. And as long as they're not getting restriction for say, forget out of the bed, you can, really help, let them use the incentives parameter, help them let them walk out of the bed to the chair. These are some of the things that we can try to tell them. And then, the coughing and deep breathing, exercises them, then what you do. But the only thing though, we can't do coughing, you have to be careful depending on which type of surgery we then do. Because some surgical intervention, then with the cough, you get to use a splint technique, meaning for use like a pillow or hold the incision, so we cough like go open the wound, because when that happen again, the person can end up for go back now hospital and want for do a double surgery while you still they try for heal. So you can ask questions and also ask which activities then okay for let you do and which not okay for let you do. And the other thing is judicious administration of opioids and sedatives. This is very important because sometimes when we go through surgery, they expect to let them give you medication for the surgery, because they're not going to give you just Tylenol. It depends on which type of surgery this is. Tylenol, ibuprofen, then can get handed to you like, but somebody will just go through a major surgery, really go need some form of opioids, narcotics, we then go need. But when they take their medication there, so it can really suppress your oxygen, your oxygenation. So the nurse can always tell you, say, yes, you get the medication, but like the one that you get within certain time. Because you get to educate the patient on the side effects, because if it causes that respiratory depression, then the person now they're at higher risk for, then kind after surgery when atelectasis, a collapse of the lung, you want to educate them. You also way they take them. You get to ask questions as to why they take this. What are some of the side effects? What are the benefits for me? It will really be helpful. Some medical management we can to lung problem. First, they can do chest X-ray. They can obtain a sputum, where then will send to the lab, and then they can start for treat you with an antibiotics while the lab they analyze the sputum for see which kind bacteria or infection you get at the lung. So that now, but sometimes again, when the results come back, you can see they don't start you on one antibiotics, then they change them because of the sensitivity. Sometimes some antibiotics them very resistant to certain antibiotics. So if you tell you, say if like the person get a pneumonia, the antibiotics, we go treat this pneumonia, it will tell you the different types them. So the provider or the physician, they go based on that. The other thing is people then wake you and say, I get cold today, then they go see the doctor, then one for then treat them with antibiotics. Then therefore be very careful. Depend on how many days you really get the cold. You want really for let your body fight the virus. Especially if you have virus, you don't need antibiotics. You just need supportive care, drink fluids, get a lot of rest, can really help. Instead of, you every time you want to take antibiotics. Because when you do that over time, what can happen, your body, they become very resistant to some of them antibiotics. And we get some infection, then we really need maybe one or two drugs, you go end up for day in a hospital, they get what they call a multi-drug resistance. Them patients, then we can really keep them on isolation because we find out, say, then they get multiple infections that way be say they don't try different antibiotics, we not work for that. So definitely be careful when you get a cold, when a virus, try for do some home remedies, unless the that cold they don't pass 7 days, definitely seek help. We don't see, you don't try everything like over the counter, things that we do now host, you don't try, help. See a doctor. The doctor self will actually recommend to like take something. Or if not the flu, then we'll treat you with a Tamiflu or maybe say for use within 48 hours, of your symptoms. But in many cases, we can prescribe them because that can make the person feel a lot better. So supportive treatment, we don't talk about why I mentioned fluids, oxygen for if they hypoxemic, antipyretic, meaning, fever medication, antitussive, decongestant. So things are normal for make them feel better because we talk about a viral illness in some cases. And in some of these cases, the patient can benefit from a little oxygenation where maybe like 1 to 2 liters if they're in a hospital setting, So, and also administering antibiotics, depending on, whether or not the grams staying within are the results. So the treatment is based on the culture with them you don't obtain. And antibiotics definitely, like I said, is not indicated for any viral infection, but they are used for secondary bacterial infection. And that again will go to somebody will get asthma. They already get a lung problem. They don't come in, you treat them you treat them with steroids, you treat them with a bronchodilator, and now you don't want to let them get pneumonia. So for that reason, you can treat them patients there so with antibiotics when in a prophylactic way. So the scenario is different for somebody who gets COPD versus somebody who not get no underlying lung condition. These are some delivery ways how we can deliver oxygenation, way be say via the mask. Like the first one, we not the letter A, now a Venturi mask, and then they can do on percentage. And really now one of the effective way for somebody who gets COPD, will let it deliver a precise amount of oxygenation. And non-rebreather you see there, and also you see a partial non-rebreather mask. So there's a little bit of a difference in terms of how much oxygen this person they get compared to somebody waiting on a nasal cannula and somebody waiting on a mechanical ventilator. So these are all based on percentages. As we mentioned, anything above 21%, you do and really for like you reduce, some, like the workload of breathing as well as decrease the demand of oxygenation on the heart. So you really need them for like pump the blood out. So you really don't want to like work hard too much in doing so. And these now are some of the different things again, in a way, like somebody way then intubate, you will see the top part there. Now, possibly they don't intubate, for about, so the thing with intubation, we want to understand is not to, so first of all, what can happen, the endotracheal tube, what they do, they provide patent airway for somebody so that then we'll get access for connect them to a mechanical ventilation. And also it can facilitate the removal of secretion. So meaning the tube they down your throat, you apply suction for remove, secretion, so the patient, will clear, like because they're not able to clear their throat because they don't get like a massive stroke, they don't get some kind of ARDS, motor vehicle accident, where they're not able to do nothing for themselves. So, they don't come in with a stroke. So then patients there, depending on the type of level of stroke too, not everybody require that. Some patients their stroke can, resolve very quickly. The ET tube, meaning the endotracheal tube, can be in place for no more than 21 days. So about 14 to 21 days, the need for replacement to a tracheostomy. So the tracheostomy, now this one we did done so, then therefore do an opening at the person in, around the person in throat, for let them not go destroy, destroy the vocal cord, because then in a voice box, right? So some people then can really go through all these problems, then can do well afterwards. You can see the hole with them for some time, but it is closed. So during that 10 days, then can they use like a little microphone for talk so you go hear them? But they don't want like, for really keep the tube down for that long, because if they keep the tube down for that long, where the person really get out of the need for mechanical ventilation, then we're able to go through therapy and then, eventually then we'll, talk again. Yes, the percentages are low, and people then we can really do well after, a tracheostomy, but you get a lot of people then back really do well in that light. And the one here with this avatar, somebody will get a nasal cannula, meaning then get like a little oxygen, device, when at the tube, now this person, somebody with it on an outpatient setting, meaning, they're not a hospital, but you need the nasal cannula, like the COPD patients, we can discharge them with a nasal cannula. We just get for putting so many different recommendations. Then we get a care manager, social worker for help them, in facilitating, making sure they deliver their oxygen to them. When a portable oxygen tank, like a very small one, not to the one within the hospital setting, so that then we'll really go around the community and also, live with them, family members, them, not feel sick and feel so stuck in a hospital setting. And this now how the lung is. So if you can see now, so the lung really you see a collapsed lung. So this all we see around here now like the air and they within the lung, and also and you can see now the normal lung tissue how it's supposed to be. On one side you get 3 lobes, and then on the left side you get 2 lobes. And the reason for that, not within right here, I did the heart day. So it's just that they remove them, but from this picture. So, and again, you can look at this here, the airway within the lung. So you see the lung, the way the picture is look like a tree. You get trees with branches them. Where we say all they are then very vital in how somebody in oxygenation they go. And the other thing again, where you will see they happen now, you see this not a normal alveoli, where we say you need them for really let cause tension within the lungs, as well as for help with how we breathe and things like that. Because, like, for example, people that will get COVID, it can affect their alveoli. It can destroy the alveoli, and you can see a lot of them where they can intubate them, because now this person don't get a collapsed lung, due to this virus we didn't get. So now, so a normal alveoli for look like. But then this now the one now we get inflammation, like swelling within the walls of the alveoli, and it full up with like fluid, like pus, some air. Maybe say it can trap, within, like, in some of them can get like a bacteria, as well as some blood cells and can get it. So this not what you want for see, and this can happen to somebody we get like a pneumothorax. And patient them with endotracheal tube or tracheostomy, which you want for really see, what you go to see with them, they can get issue with communication, and that's why they're not to keep the tube in for that long. It can cause anxiety for them, because if they get enough air, you definitely go for be anxious, right? Because now your brain and everything not work together. They need to work together, and then the person can become like get knowledge deficits. These are some nursing problems. Then can get this ineffective airway clearance, meaning they're not able to clear then sputum, then secretion, then we need for suction them, and also then they are high risk for infection. So definitely, really doing care we can to infection control measures them in, like, somebody where they work in a hospital know how to deal with the tubes them, the cough, like provide oral care, and also, elevating the head of the bed, meaning, keep their head high, because that really help to facilitate breathing for the patients. Some of the other things that will happen if somebody they get oxygenation, not toxicity. So it can cause complication, even though we know say oxygen, they benefit from them, but if you give too much of the oxygen, what it do, it suppress the respiratory drive, and cause low oxygen tension. Thereby, not CO2 no more, because the person, like, for example, I want to go back to COPD. They're not able to get rid of a lot of carbon dioxide. We not the one we need to get rid of, and the one we need within your body, not the oxygen. So giving them too much, and I make they say somebody will get COPD, they give them 2 to 3 liters of oxygen. And if their oxygen saturation is within 90 to 93, they're fine. They don't have to be within that 95%. We're not for somebody we not get no health problem, in oxygen saturation for the 95 to 100. Okay. If somebody get oxygen toxicity now, because the concentration of the oxygen is greater than 50% for the intended period of time, meaning more than 48 hours, and then it can cause overproduction of free radicals, where it severely damage some of the cells down. So you don't want to give too much oxygen. You really want to make sure that the oxygen is appropriate, for the patient, and they not forget beyond what they need, and for the number of hours we they need them, for days then we they need them. And some of the symptoms, and somebody for so say this person they get oxygen toxicity. Now, for example, like they can get like a substernal discomfort, so like in the middle of their chest. They can get paresthesia, meaning like they can like numbness and tingling sensation, pins and needles, for example, or they don't feel anything. They can get dyspnea. They can become meaning shortness of breath again. They become restless. Then they become fatigued, malaise. Like can get some progressive respiratory difficulty. And also refractory hypoxemia, as well as, alveoli atelectasis, when are the collapsing of the lung. And the alveoli infiltrates, now we then do a chest x-ray, then we can see that. How we can prevent something like this? You want to really use the lowest effective concentration of oxygen. That's not the key here in how you can prevent oxygen toxicity. And the patient that waited on mechanical ventilator, then they're on a setting or a mode, what they call PEEP, which now a peak expiratory end pressure as well, continuous, passive airway pressure, we not the CPAP. And then they do it prevent and reverse any atelectasis, and at the same time, it allow for let the person get enough oxygen based on, the percentage. As we then, people that would work in a hospital know this, you get a order, the title volume, then will tell you how much they want for give patients. And so you get to follow that order there. And it's based on the person in weight in kilograms, and the formula they will then will use. Some patient teachings, then we come to oxygen therapy, definitely safety. Safety in a sense that, if you use oxygen at the house, you get for watch the electrical outlets, the mic, the stove, like you get for use gas cooker, and then the flow rates for teach the patients how, or the person, how they really get for use the oxygen within the home setting. And also if there's any issues, how they get for get help. Teach the family member them back, because if the family member, therefore they're part of this patient in care, where they teach them, they tell the family also, because we all go on for no what thing they go on with the ma or with papa or with brother or sister where they live with we, as to what thing and they go through and how we go able to help them. Because when you see loved ones sick, you really want to be involved and do your own part in any way that you can. And also how they therefore reach out for get supplies, and some of the other things that we will teach them, the position, the coughing, breathing exercises them, and how them for address the pain and then the discomfort as well. Then that brings us to the next topic for we don't done with oxygen and why we need them, why it's important to us, but now we want to talk about hypertension, we're not the same as, high blood pressure. So now a condition where we say it really cause a huge force, against the arteries them, that, we'll get like the walls of the arteries that it cause like a big force where we say dandy now it's too much for the arteries and for for sustain. Then people then can now get this because either then they smoke or either then get some stress where they go on, or then get like a strong family history of high blood pressure, or because the person not they eat healthy, and then kind of they or then overweight. So many different things that can lead to high blood pressure. So usually a blood pressure above 140 over 90, is, and then they consider this, as, hypertension. And in some cases, some people can get like a severe form of high blood pressure. In those, we can call them hypertensive emergencies where they need for going to the hospital so that they're not going to develop stroke. And high blood pressure, sometimes then people not can get symptoms for a very long time, and if they're not treated now, then the person will begin to exhibit some of the other problems. So if you see anytime you go to see your doctor, then check your blood pressure. If it's high, then can tell you say, now for watch your diet, now for lose weight, now for avoid certain things that we get too much salt. Why make them they tell you that? Because they know say they at a stage where we will take care of them, we will control them. But if you continue for the get high blood pressure in different visits them, then can end up for put you on medication. But before they put you on medication, then they try diet first. So if the diet, exercise, and lifestyle modification really help to control the blood pressure, now the best thing you will ever do. But because we begin take medication for them, you forget say you need for at the same time as you take medicine, you for also, do them other things that we don't they tell you before. So in combination, you have to do everything. But sometimes we can see say people then can forget or they know they follow this and then get very strong family history when it comes to high blood pressure. And with that, we think can happen, the person can get some heart disease or then can develop stroke, and really when you get a stroke, you deal with an attack, on your brain. So the brain really, they coordinate so many things. Then, the person may not eat healthy, but these are some of the things they should be doing, right? And also sedentary lifestyle, not something where, for staying at home all day, you watch TV, they do nothing, just, let it move around, and they really help your blood pressure. And also, if this continue, we think can happen, the person they get decreased cardiac outputs, which can lead to ineffective or inadequate tissue perfusion, and also it can cause shock syndrome. So if you get ineffective tissue perfusion, meaning they get enough blood flow by you tissues them, all the different organs because why? You out not a really pump out enough blood flow, as we talk about what can happen when somebody get a lung injury, within the body they try for do here, and within some of the things and where the body can try for pet for how to address the problem where they go on. So some stages then for hypertension, actually you should have said HTN, where they deal with here, hang on. Okay. So stages of hypertension, they talk about stage 1, you look at anywhere where we say the top part. When they say systolic, they mean the top part. They around 130 to 139, millimeter mercury. And then when you talk about the bottom part, when at the diastolic, where the heart for the relax, because the systolic now where the heart they work, it is around 80 to 89. And then for stage 2, they talk about at least 140 millimeter mercury of a systolic blood pressure or a diastolic blood pressure where they at least 90. Now that they call a stage 2 hypertension. And then sometimes people then can get something we then call isolated hypertension, meaning it is above 130, then it is a little under 180, for some time, and then, isolated hypertension, where we say, you look at this range there, so can go on for some time. I think that some of the tendencies where you can't see you physician or you provider, then begin to talk to you about what you for do, for let you go really take care of you yourself, for let you go develop the hypertension itself. So you did like above, either you equals to 130 over 80, or it's like a little above that, right? So the person can get that mix, variation there, but really need for do best in terms of what they will do for really prevent the actual diagnosis of hypertension and also other complications that will happen. This now just some of the things that we will try for change. Look like modifiable means, if you exercise, you try for avoid excessive salt. So you can really try for avoid that. But before we even go to that, there are a few things where we say we're not going to change about ourselves. That way it come with we just get for deal with it, right? If you get a family history of high blood pressure, you know that you're at high risk compared to the one way not get no family history. Like for me, I get a family history of high blood pressure. I get a family history of diabetes. So then 2 health problems, and I know say I get for watch what I eat. I know say I get for try if we've got when they drink, but like if me not possible with the do anything and I go for avoid the excessive alcohol consumption, and also I go for try for exercise. And these are things that we will try for change within your daily lives or daily activities of living, right? And also, you want for avoid smoking. Dandy back now that thing we could try for avoid, even though you're not on this list. And if you're not possible get some mental health problems or you go through some stresses try to cut down on the stress. Maybe go exercise, go for a walk, do something where you lack, where you stay out of the stress. It can really help control your blood pressure. And also somebody where really there's a deprivation, then they live in a very low economic status, it can really affect them in how they can manage their high blood pressure. Why this important? This important because if you think about it, if somebody not get money and then say like you eat something healthy, for eat lean meat, if you eat fish, compared to eating steak, where we say that it all will raise your blood pressure, they afford them. Because you're not able to afford them, it will lead you in that light for make you blood pressure, you're not able to control them. So that's not something again where so many people then will go through, yes, then they do everything within them power let them control the high blood pressure, but then can face some financial constraints, for food and the right diets. Same goes for somebody who get diabetes as well. But now, again, the other thing where you're not able for change, now you age. As we get older, some will add to we age, right? So for me, I know already I'm not going to go under 39. I'm only going to be, higher than that, right? Next year I'll be 40. And then, you talk about the next thing is, genetics, right? So family history, again, we talked about you gender, being that you're a woman or a man, you have no choice. You're just going to keep that. We're not going to include the one that they change them, then gender because of their preference, but we just talk because of your gender, you cannot change those things. You can only change the other one, not the far left. Those are things that everybody can try for do so they can cut down or avoid what high blood pressure can do or what it will lead to. So this now the Joint National Commission for Hypertension. This now the algorithm, meaning this now the guidelines within the follow, when it comes to high blood pressure. So somebody with it above the age of 18 and above with hypertension, then one follow you start by implementing lifestyle modifications. And then you get a set blood pressure goal for this person, yeah? Let you know, say, now this now the blood pressure goal wait if we reach, right? Maybe the person don't come at your office or at your clinic setting, or you a patient, or you and your family member when I don't go to the doctor, and they don't tell on us, say, okay, you get for really try like blood pressure there around 135/80, right? They don't give you a number. So that number where they don't give you, they want to let you maintain that day, they want to let you follow that day and let you follow the diet where they don't put you on. Right? So, and also you, in some cases, then they alone not can help. So what they can do, then they give the person medication, right? So if you look at this algorithm here, what they say for a general population, we not get no diabetes, not get no kidney problem, then they at the age of 60 and above. The goal for them blood pressure now 150/90. If they less than 150/90 for somebody we get where they above 60 years of age. But the one now where they under 60 years of age, the goal now 140/90. The one that person they understand say you they under 60, you really get for trial your blood pressure they less than 140/90, right? And again, the next thing where you get for look at the person now where get diabetes or then get kidney problem when a chronic kidney disease, it can be a stage 2, 3, 4 or end stage, right? All ages, meaning all ages, they're not even categorize the age. The fact that you don't get then 2 problems then they, or either one of them problem then they, you risk it higher for get complications where it comes to high blood pressure like stroke, and heart attack. So, and with those patients, the goal less than 140/90. And for the one them, for all ages and race, CKD, meaning chronic kidney disease, again, with or without diabetes, the goal now so less than 140/90. Then they change them. This is now the Joint National Commission every few years, and they meet, then they come up with guidelines them where people them for use as clinicians them, and this for use and this for tell the patient say this is what's going on. But now if they're not able for really control their blood pressure and they're already at risk, somebody with diabetes or kidney disease, what they can do, then they give them ACE inhibitor or AB, where now like either a losartan or lisinopril, right? They take all 2 together, never. You can only take one. If you take the lisinopril, it causes symptoms. For example, it causes dry cough, where really bothersome. You tell your doctor, they can change them to losartan, right? Because this medication, then they do the same thing. So you know, go give the person the same medication, even though not like a different class or different brand, but they all they do the same function. And it gets a protection on your kidneys. So sometimes you see the patient get diabetes, but they not get high blood pressure, or they not get no other problem, but they put them on a very low dose of the ACE inhibitor or the app, right? So like Daniel, the key thing here, if you doctor say, now for stop the lisinopril because it only give you problem, take this one, discard it, don't ever take it, right? So you don't want to do that. And the other thing, for somebody when like African American, Black, so you race again, it can play a key role now. So the non-blacks, what they can do, then they give them like a diuretic medication when a thiazide, you can some put them on hydrochlorothiazide, they can give them the lisinopril or give them the losartan, and or in combination, in some cases, they can give them, and then they give them back calcium channel blocker, along with those medication, or they can just do them alone, right? And for the person when are African American or Black, they can give them, just the thiazide, when are like hydrochlorothiazide, like a diuretic, a water pill, then give them in combination or alone. So it could be with a calcium channel blocker or by itself. That again, then what they do now, then they reassess. At this point, what's in the person in goal? They don't meet this goal. If they don't meet the goal, you just continue the treatment and you continue for monitor the patient. So, but this again, now a teaching point for the patient for letting understand, see, just because your blood pressure is normal, not mean say you for stop for take the medication. You get criteria then, you get parameters then where you get for stop for take the blood pressure that the physician or the provider can determine. But when you take the blood pressure, as long as it is within the normal range. We'll talk about normal range, meaning your systolic blood pressure, the top part of the blood pressure for day 90 to 140. And then the bottom part of it for day 60 to 90. So if your blood pressure there within these range, you still continue for taking blood pressure medication. And if you feel say they continuously decrease and you're on 1, 2, 3 different blood pressure medication, reach out to your physician or your provider, make them adjust your medication, but not stop the medication on your own, knowing that it will end up going in high, because the next time we then go check them, it will go high. And we can see a lot of this in many times. The patient, they say, well, I did not take my medication. My blood pressure was good, and you can see this again with many of we foreigners, them Africans, Asians, we're not to understand, really for understand, see, them for continue for take the medication regardless of what they go on. So you get for continuously educate them, say, as long as your blood pressure is within this range, you need for continue for take the blood pressure, get the machine at host, check your blood pressure, and at the same time, reach out to your doctor or see really what I want for like do. So this can continue on the goal. You always continue for reassess them. If you continue to stay the same way, then you just continue to monitor and then the same treatment. But if you not work, what do you get for? Do you get for maybe this person? If you look at it, sometimes you start with one blood pressure medication, but then it puts you on the second one, because the first treatment plan where they don't put in place for you, either you do them or you skip, right? If you do them, you need to skip, you really do a lot of stuff, and you don't do all that in a way where they talk about modifiable risk factors. You do diet, you do the dieting, you do the exercise, you avoid stress, and anything, and then the alcohol consumption, you decrease that. All that in and they again can really help you in how you monitor, like how you get avoid for day on multiple medications, right? Because in some cases you have patients on multiple, and Lord not forget, all them medications they also get them risk and get them benefit, right? Especially on your kidneys, and and some of them you call them nephrotoxic, and your liver as well. So, and in many cases, we talk about the kidneys now. So So that's not something where everybody for understand. If we get family members, then loved ones, them where they live with high blood pressure, try for educate them on things that we then will do really for control the blood pressure and try to adhere medication compliance, lifestyle modification. Now way to go when it comes to high blood pressure. That's the green section, just the talk for the provider or the clinician in how them for deal with managing the blood pressure, and some lifestyle modification or changes them where the patient or the person will do now to avoid smoking, and also, try for control their blood sugar. If not possible, they eat a lot of carbohydrates and try for eat healthy. Example, if you try the DASH diet, we in a dietary attempt in stopping hypertension. Now that's the dash mean. So moderate alcohol consumption. You want to reduce your salt intake. And also physical activity, moderate to vigorous, and activity, and about 3 to 4 days, in a week, in average of about 40 minutes per session, right? But even if you're not able to do the 40 minutes in the beginning, it will be nice. Let's just start with 15 minutes, and every day you can just add to that. When you add to run, what you really they do for yourself, they really get yourself in the place where you really lack the idea for safe, for walk, for exercise. We know a lot of stuff can go on in a person's life. You need to give you chance for you exercise, for you do the things that we want to do, but you get to start somewhere, especially when you don't diagnose you with a medical problem, then and then you get for really try for work on, because if you not do that, it will lead to another complication where really somebody, maybe the breadwinner for the family, the one where they take care of the family. So many people then depend on you, but you get for doing for them. Sometimes in the area patient they say, I have to do it. I really have to do it for my children. I have to leave, for my family and things like that. And I'm sure we all think in that direction, especially something where say you change, about yourself. If you do able to change that, you work on it, and then eventually you can see that difference. Each time you go, the doctor tells you, no, you're doing really well. Your cholesterol is down, your blood pressure is good. You've given it your best, right? You've done your own part. So it's really important that, we take on in that way, in a positive way. And some of the other things that we can happen. Somebody go to doctor's office, they can get this, like maybe that host, the blood pressure is normal, then they take their medication, then they do everything right, and they get this white coat hypertension during the doctor's visits. And then their blood pressure, they elevate, right? So I don't even get a patient in, not to the blood pressure, not the heart rate. I did so many different tests just for find out what in the cause this woman for become tachycardic. Tachycardic meaning elevated heart rate. Didn't find anything, but we end up finding out she has other stressors that really was doing that to her. And every time she comes to the clinic, she have this heart rate of 120, 180, different medications. So cardiologists did so many different tests, nothing. But it was all related to, personal issues and the facts they would encounter at the doctor's office that they tend and they experience all that thing there. So, and then you get something where they call masked hypertension, where it be say it's like now a consistently elevated by out of office measurement, but it does not meet the criteria for hypertension. Even though the numbers are high, but you not go diagnose them because, it's like always they in high. Like myself, some days I go, my blood pressure, it is on the high side. But then, I can talk to the person to do the blood pressure. I say, maybe we need to wait, and maybe you need to, like, I not can let for let people that know what I do or teach right away. I can give some time for let the person do it, then just tell them, maybe you need to do this, and then we can change them, and I can see a drop in the blood pressure. But myself, there's times when my blood pressure can be in the 140s, that's high, right? So, and I already know my risk factor, it put me at high risk for hypertension. So many of us, maybe when they listen today, know say we get a high risk, and then we just before do the right things, and we go avoid getting complications from high blood pressure. Again, risk factors was age, obesity, family history, which we say, these are things you're not able for change. And sometimes when somebody get high blood pressure, they can become very dizzy, like sometimes they can pass out, when they become faint, headaches, sometimes when they get chest pain, they can get trouble breathing, swelling at their legs, then they become very tired, or they can get swelling at the stomach, and some heart problems, and they can also get like vision problems, like blurry vision, as well as nosebleed. These are some of the things where you go experience where you get high blood pressure. Then some people can get some problems, and we be saying that it has to do with the nephrons, can lead to then hypertension, or because then they eat too much sodium, which like more than the 2 grams, and then people then can also on a risk factor than they for high blood pressure. And alcohol, we don't talk about, physical inactivity as well. And I just want, I feel say I've been just one mention, since we talk about, we own nation, Sierra Leone, and I try to go to WHO. This is not exactly what's in them, right? We can to high blood pressure. WHO say hypertension, also known as high or raised blood pressure, is a condition in which the blood vessels have persistently raised pressure. And then blood is carried from the heart to all parts. It's just like one, like that layman we did read WHO, understand, so the vessels, and each time the heart beats, it pumps blood into your vessels, and the blood pressure is created by forces, of blood pushing against the walls of the blood vessels. So then define high blood pressure, and exactly that can happen. The higher the pressure, the harder the heart has to pump. So if your blood pressure high, you really make your heart let it pump too much, and that again not good for you, your heart. So hypertension, as we know, now a serious medical condition. It can really put you at the risk for heart, brain, kidney, and other health conditions. And a major cause of premature death worldwide. So that's now a key information, and for everybody to understand, if you not take them seriously, sometimes then they just see somebody don't die, but waiting kill them, they don't know, right? Or then we don't really know, see them get all them symptoms and what I just went over, but they not be they taken serious for seek medical help, then kind of thing, and they on something where we therefore look into. And again, look at the statistics what they talk about here. It said with upward of 1 in 4 men and 1 in 5 women. So with this particular health condition, men, then they are at higher risk. So men, then they get high blood pressure more than we, the women, them. But there's so many health conditions that when a woman, then they take them on board. So men really need to take it seriously. And you can find out is sometimes men are the ones that is very hard for let them become compliant with medication because of the side effects where some of them blood pressure medication then get, where they affect their sexual activity, and some men don't like that. But they have to really look at the benefit, look at the risk versus the benefits we can to taking the medication. So that's not something where I want, for all those listening, if you really are one that is diagnosed with high blood pressure, your risk is higher, and you should really try your best for let you go take the medication. And also then she say over 1 billion people then they live with high blood pressure worldwide. This now in WHO report. So the burden of hypertension is felt disproportionately in low and middle income countries. So we get to understand we are among that as Sierra Leoneans, and some of them things that we can see where people are not can take them very seriously, then can end up for the hospital. Before you know it, they don't say the person don't get a stroke. right? And then, we say, 2/3 of the cases are found, largely due to increased risk factors in those population in recent decades. So that now again, it all therefore deal with, nation like Sierra Leone, along with other West African nations. So we therefore really take serious, and know when to seek medical help and not waste time. Because if you waste time, you get a stroke, and then we get a stroke, now additional problem, we go want to see your loved one to go through. And again, here, this is just the same thing, the narrative where I've been just on talk about. Most people with high blood pressure do not know they have it. Like 1 in 4 men have hypertension, while 1 in 5 women, have hypertension, right? So within all them people that we team up, one per them, you go put 5 people then right now salon, when a woman them, within that 5 people then you can find out, say, 1 of them get high blood pressure. Same goes if you go put 4 men in a salon, so about 25%. That's a high number. That's very high when you talk about somebody in health, right? While, with the women then about 20%. Some other major causes then we come to high blood pressure. You talk about prescription medications, them can make you blood pressure go high. Some over-the-counter medications, them. Some oral contraceptives, them. Particularly the one that we contain estrogen, then they can increase your blood pressure. Like NSAIDs, we talk about like Motrin, Aleve, or ibuprofen, then medications, and they can elevate your blood pressure as well. Sometimes some cough medications, them, some antidepressants, if somebody they go take some medication like SSRIs, tricyclic antidepressants. These are different forms of psychological medication where some people then they take for anxiety or they take them because of depression, can raise their blood pressure. And also corticosteroids, meaning steroids, them, mineral corticoids can also increase your blood pressure. Sudafed, pseudoephedrine, them medications, and some weight loss medications, them as well. So be careful if you're not somebody where they're on a diet pill, can put you at risk for high blood pressure as well. Sodium containing antacids, like if you get heartburn, you're on some of them medications and wait for relieve your heartburn, but it can really put you at risk for elevated blood pressure. As long as, and then again, it's not saying that all them medication we then they put up here, for take them. Then just to say if you take them, let's take them in moderation, because if you continue for the take them, for a very long time now, some of the effect, and then you've not person we get high blood pressure. You have to be very careful, read the labels them and see what it is say. Because now you go there, you not person, you don't follow the diet, you don't take the medication, you don't do everything what the doctor say like you do. But not knowing if you don't take some over-the-counter medications and because you get a cold or you get pain, you get arthritis pain, so you decide to take Motrin, then you just elevate your blood pressure. Then every time we go to the doctor, say, you're not doing what you're supposed to do. But deep down within you, they really follow all the things. But then if they go through the medication reconciliation, then they find out you're on some medications where they raise your blood pressure. So it will be very important that you relate the information and they also. So erythropoietin, when a hormone, and cyclosporin or tacrolimus, now other medications, them we go, so everybody get for take them 2 medications and they, but now some of them medicine, and they again, we will really raise your blood pressure. And some of the other stuff, this again, a whole different like oncology medications, them. So I won't read those, but they are there. And illicit drug use can really affect the blood pressure, such as meth, amphetamines, cocaine can raise somebody's blood pressure. If somebody get a primary renal disease, whether or not a chronic, can lead to high blood pressure. If they get some hormone disorders, then like aldosteronism, can really cause for that person, they let it get high blood pressure. And obstructive sleep apnea. So this na a disorder where na it affects your breathing, during your sleep, and can cause somebody for like a systemic hypertension. And the other thing here na pheochromocytoma, when a real cause of secondary hypertension. About one half of the patients then with pheochromocytoma tend to have proximal, hypertension. Most of them, can really appear with primary. And this is important for me for that, just expand on it a little bit. Get a cousin of mine, then do a CAT scan. Actually, she had something that happened. It was during the Ramadan. Then they rushed her to the emergency room. We then rushed, and she ended up being intubated. And not only did she got intubated, the CT scan showed as if she gets a renal cell carcinoma. The first thing they thought about is cancer of the kidneys, right? Because they can always defend a tumor in the kidneys, unless proven otherwise, then they take as cancer of the kidneys, when a renal cell carcinoma. But in your case, I've been there with time throughout. Take the point for surgical intervention, then go for the first surgery, waiting in Abidina Mount Sinai. Actually, in a day we go. During the surgery, because I don't say now, like for removal, it can leave with one kidney, for during the surgery, in blood pressure shoot to a level where they're not going to continue with the surgery. So they terminate the surgery, which was a good thing, right? Not knowing she has pheochromocytoma. So it was where in our hospital now, then get endocrine on board, where they deal with the endocrinologists, where they deal with the hormones, now therefore do all different tests for find out, say, now this even get. So now like a tumor on the adrenal, we push inside the kidney. Like now when you push inside the kidney, it make it look like a kidney cancer it get. So now she did not have, she had the surgery, but the surgery wasn't done for the fact that she has to lose the entire kidney, and then it was related to cancer. Yet it wasn't related to cancer. It was because of this particular problem where they present itself, in certain stage, so really anytime like they do a CAT scan, you really want for make sure say them do blood tests for say really not for this not the problem, because they can do a special blood test for this particular diagnosis. So I be just feel say that not something, because every time I get like a personal or like experience, I feel say it good for a lot of people to understand and also really remember say we did live with family members and we seek, you ask questions, and also hope that, then will really do the right thing, the right thing for the person, but that time, if we don't go through the surgery, for the initial intention is a cancer of the kidneys, well, the second surgery was planned correctly, was planned well. She's doing well now, so we don't even have to, I'm not saying nothing would happen, but in that particular case, because there was no family history of cancer whatsoever, they did so many other things, just to see what's really going on. But they find out it was pheochromocytoma, right? So it's very rare, but it can cause secondary hypertension. This I don't already touch on, now some of the things and way, you do, like when somebody come in, how to take them blood pressure, make sure you use the right cough, and make sure, the patient not smoke for at least 30 minutes before they come to the doctor, because we don't smoke like one, like say how many sticks of cigarettes, you come, then check your blood pressure. Trust me, it's going to be high, right? So these are some of the things that, just like the techniques and the proper way of, checking somebody's blood pressure, they have to be in a resting, position. The arms, has to be rested, so, and all the different things in how for really take your blood pressure so that you get accurate reading and using the right, the correct cough, because if they use something way too small, it'll give high blood pressure. If meaning the blood pressure will be elevated. If they use something way big, again, it will give falsely normal or low blood pressure to start with. So it's very important that the cuff size when they use, not too big, not too small, right? So that now and a very important thing we can to take in blood pressure. So this again, now a diet, we're in the DASH diet. You can see the plate, it deal with more vegetables and like half of it for deal with fruits and vegetables and on both plates. And then you can still eat rest because we are Africans, them, we if we not eat rest for the day, we take and say, I not eat it. Not me, I not eat it. Let me tell you, if you are one of those people, I'm like that too. So we are on the same boat, but you just get for substitute that carbohydrate for something else. If you eat rest and you're not passing back with like sugar, bread, you like pasta, you like anything we get carbohydrate, get for avoid dandy, they eat less. But even that again, try for cut them down, right? So you can't have too many starch, So that now a quarter of your plate, therefore be, the rice, chicken, fish, and try to avoid meat, red meat, because that then can cause you forget high blood pressure and also can lead to cancer, right? Especially colon cancer. And here again, this is now the DASH diet. We're not a dietary attempt to stop hypertension. So this is not the chart. It'll tell you how many irons, protein, carbohydrates, sodium. With this particular chart, they say 1 grams of sodium, so people have to really adhere, and the calcium as well as the fat. And the time that we try for eat, you can eat 6 times, or 5 times a day. You get your meal, then you get snacks in between. It can really help with your metabolism and how you really burn calories. And in here again, some pharmacological, measures them. We don't talk about the weight loss, healthy diet, reducing the intake of sodium, enhancing the intake of dietary potassium, physical activity, and also moderation of alcohol. So if you see right here, what's in really the see going on here, if somebody follow these measures there, it can really reduce their blood pressure by 5 millimeter mercury. And also here, if they get all the other issues, then it can reduce that blood pressure day by -3. So doing each of these, really, if you do the math here, you're going to see a significant improvement on your blood pressure reading. So if you look at it, just weight loss diet, so -5 and then -11, that gives you 16. So if you're not possible, your blood pressure be then always like 145 over 95, take that down. So you're really gonna, make yourself happy, your doctor happy, that they don't need to put you on the 3rd or 2nd medication, right? And then if you reduce the salt, then it can range from -5 to -6 millimeter mercury. And then, if you try for take in, potassium rather than sodium, you can see the difference here. But be careful when it comes to the potassium, because some medications them can cause or let you potassium go high. Potassium, now one of them electrolytes them. If you do on diuretic, it can deplete them. But if you do on like a lisinopril or losartan, it elevates your potassium level. So where that can happen, it is at risk for, if you get low, it can cause some heart issues them. And then if it's high, now you're dealing with your kidneys. So be careful in terms of, wait and see potassium, and just go based on the recommended amount where you need. But let you keep on at the range of 3 to 5, not the potassium, certain electrolytes are day for day, they pass standing. we pass on a problem. Then give you medication for bring them down, or then tell you, say, if you're not possible to eat a lot of bananas, you're not possible to eat a lot of green leafy vegetables, definitely cut down on your potassium because you don't want to have cardiac issues, so, or kidney problems. And then if you think about, aerobic exercise, that's not a huge one, again, along with the diet, you did talk about -5 to -8. And then the alcohol, again, if you do that in about 4 millimeter mercury. Okay. So these are like just telling you, if you do any of these non-pharmacological interventions, them you can still do well with the blood pressure. You can avoid, medication, we cancel all them different things there. And then alcohol, then say for men, you should drink less than 2 drinks daily if you decide for drink, and for women, less than 1. And that can cut down the blood pressure by -4. Medications we don't talk about, where now the angiotensin converting enzyme inhibitor, we not the ACE inhibitor, now a vasodilator, where we say it, also it can cause some diuresis, it decrease the afterload, these now other medical terms, them where I will stay away from, but like, you want for monitor the person for hypotension, meaning because when they take blood pressure medicine, they lower the blood pressure. You want for monitor the person for hypotension, meaning low blood pressure, and also monitor this person for hyperkalemia, where I mentioned when at the high potassium, and also altered renal function, as well as cough, that dry cough. If you continue, then they switch you to the next one, when at the angiotensin 2 receptor blocker, right? And this one, then they prescribe as an alternate to the ACE inhibitor because of them all they work similarly. And you now go take them all two together, not just one. So then they are the lisinopril, the first one, then the other one are the losartan, And then hydralazine and isosabide, this now another alternative to the ACE inhibitors. And you get beta blocker, we now like metoprolol, or propranolol, these different lols, as you get them, you can look at it, you can see the classification for all the different medication. So then can prescribe them in addition to the ACE inhibitor, but it may be like several weeks, before you can really see the effect. And then you have to use them with caution. If you're not person will get asthma, you get to be careful because it causes bronchospasm. Okay, can cause bronchospasm. Okay. So, somebody they already get a breathing problem, they get medication with it cause for let them get, another spasm, then, really it's going to be a problem. So if you're not possible get asthma, usually the clinician not can write that medication for them, then they use an alternative one. Patient education, again, medication adherence, low sodium and fluid restriction if they need to do that. And also monitor your symptoms, them if there's anything really exacerbate the problem, you report them. Then stress management, prevention of infection, and also know how and when to contact your healthcare provider, and also include the family member, in your care. Let them know what's going on with you and how they will support you, as well as the provider and the nurses that know that for include the family members. Complication of hypertension, we talk about left ventricular hypertrophy, meaning the left side of the heart therefore become very big. Heart failure can happen, both can reduce the ejection fraction. So like in how the blood they pump out of you, your heart, it can reduce that because of complication due to hypertension. And the person can experience ischemic stroke, where we say now like form of stroke when are due to lack of oxygenation, and intracranial hemorrhage, where we say now bleeding within the brain. And then also ischemic heart disease that includes myocardial infarction, coronary interventions that can be a complication, and chronic kidney disease and end-stage renal disease. So these are some of the things that will happen if somebody do well with high blood pressure. And this now a very busy slide. I'll just move past it so that we can go. But this now somebody where they experience a myocardial dysfunction, you know. So that brings us to stroke. When at the last topic we want for discuss, where this now a complication because of high blood pressure. So cerebrovascular accident, CVA, or stroke, or you call it a brain attack, just like how you get heart attack, you get a brain attack. So the terms them is like a broad term. So, but like people then can experience hemorrhagic or ischemic stroke. So, and it is basically now something where you get in one is too high, like you get 80% now ischemic stroke, while the 20% now hemorrhagic stroke, right? And again, hypertension are one of the leading cause, and also smoking are another reason for a lot of person get stroke. And because then get high blood pressure, then and they smoke, they really need to help them body. So smoking increases the likelihood of extracranial occlusion or occlusive vascular disease, nearly doubling the risk of your stroke. So if you smoke, you quit. It's very important. And nobody say quit smoking cold turkey, but like you cut down. So let's say if you know somebody smoke about 20 sticks within one pack, so every day you cut down one and try for see how you do, because we're not expect you for a cut right away, because it can cause some withdrawal symptoms. Then shows that both, like the epidemiologic study don't show say both coronary artery disease and stroke, being that it can raise your blood pressure above 110/75. So if you get any of them conditions, then they put you at risk for stroke. And brain ischemia, which is due to now because of somebody don't get a blood clot, either the clot happened within the brain or the clot, move from another place. So the E, basically they say this now embolism, meaning it don't move from another place, it don't come in a specific location. And in sometimes now they see people that will get pulmonary embolism, right? The clot now either it don't dislodge from the lower extremity to the heart, or then do some kind of surgical procedures way close to the heart, put them at high risk for developing blood clots. And that's why sometimes we see patients in a hospital, then they tell them let them take blood thinner, and they give them blood thinner, for that if you get surgery, or then make like you ambulate, early, and at the same time then can and use like sequential compression devices where we say and it puts around your leg, it compress the blood, because if you think about the way they during the surgery, then can don't, put you to sleep depending on what type of anesthesia they don't use. They don't cut you open, or create an incision, that way they don't prevent that flow, that normal flow if you go back and forth. So now when you don't then close you up, and then you really, they are at high risk for developing blood clot because of that waiting really go on during the surgery. And the stroke, a stroke is like really an acute neurological injury. It can occur as a result of any pathological processes. Approximately, like I been say, 80% of stroke are due to ischemic cerebral infarction, meaning they get low oxygen in the brain. Nine are the cause for the stroke, because now the body because of the high blood pressure, or because of some heart condition, or some blockage, because of a blood clot, the blood not flow na the brain. So, and you really, where you heart, on a normal circumstances, where the heart, they pump blood, for let it go now the vital organs. The brain are one of them, now the major one where you really need oxygen and blood flow within there, so that, you not go get other problem. As we talk about it now before, the brain and the spinal cord, now then they communicate messages them to other parts of the body, and in some cases, people then can go through a shock state, the body can try for shut down, blood flow and oxygenation in a certain part of the body, the other organs them. And the reason for that is they try for compensate in how then go able for deal with the current problem. And as always, your body will try for fat. You'll try for fat, but in so many cases, it's too late, right? And another thing here we want to understand, when somebody gets an infarcted brain, meaning like they don't get enough blood flow, it can initially become like pale, but within hours to days, that gray matter, it can become, congested with, so many dilated vessels, and within minutes before you know it, the person can end up forget like, hemorrhage, and, if there's a blockage because of blood clot, then this now something we don't migrate from another place, it can really cause problem then we can to the person in circulation in how, then can deal with, how the stroke can develop to start with, right? And where the stroke happen, it really, what it do, it cause a disruption of blood flow, not the brain. So that we don't want to see. This now just an image just to see here with this particular one here, anoxia, meaning, they get no oxygen. Thrombus, meaning there's a clot there. So you get the ischemic stroke due to either one of them thing there. So, and then, the next thing where you will see hemorrhagic stroke because there's been a rupture of the vessels. If you can see now, this part of the brain or this vessel within here, it don't rupture, it don't open. Then the person, they bleed. They get that intracranial bleeding, causing that hemorrhagic stroke. And here you can see within again another view of within they go on the brain. The blood clots can lodge within the cerebral artery. So you can see this now a clot right here. And they cause the stroke because there's not enough blood flow going back and forth. But if you can see here now the carotid artery, look so much plaque. This all not plaque within this part of the arteries. So now make if you get high cholesterol, you really want for control and they also because if you not control and this plaque, what it don't cause for let the blood not the flow or go through, all the parts the way it's supposed to go. It go, but it go very small, like the lumen is very small, right? But this now what's in a normal carotid artery should look like. Okay, so if you can see here, what's in don't happen. See that area don't become bluish, they become dark because they're not get enough blood flow at that part of the brain. Again, so we've already talked about what a majority, of ischemic stroke and also is due to diminished supply of arterial blood, and which then, they carry, the arterial blood where it can supply blood to the brain. Now glucose, oxygen for the brain because the brain need for get down and then your food down there. So if you not really get any of that, you really don't. They are at high risk, and that's because why the person get a clot, we block the flow of blood, or the person gets, a rupture of the blood vessels. Okay. And again, brain ischemia, thrombus. So this we keep going. And systemic hypoperfusion, another key factor. And here, this is important for anybody waiting out there. We talk about FAST, right? F-A-S-T, FAST, meaning somebody in face, they become droopy. Well, like now one sign of stroke. Then we tell the person, say, let them lift their arm up. They're not able to lift their arm. They cannot lift both arms, right? Because that part of let's say if they had a left-sided stroke or, on the right side of the body, now they affect. So they're not going to raise their right hand with the left hand. So because why? The brain, don't get stroke on one side. And also when they try for let them talk to you, then speech very slurred, and you not even understand them. Or, what's in they try for say to you. And the key thing here about this, now the time is very important. Like, say this person, now stroke, it don't exhibit, or now symptoms of stroke it present with, then you call 911 or you go to the nearest medical place, if they live in the United States, if they live in Europe, whatever number, emergency number, we then get out for let you use, now you use for let you call, then can't take the patient, then therefore take the patient to the stroke designated area. For let them really go and take care of the patient and how then will prevent this from happening. Usually we then can they do a CAT scan, with not a contrast, it's a non-contrast CAT scan, and then therefore do. But for we people in a salon, somebody get high blood pressure, you begin to see them face, or when they talk to you, then weak, now the arm, please do your best, let you call the ambulance service or you take taxi, you take them to the nearest, medical center so then we'll really look at them and do the right thing for them. And we know see some of the areas then will not get like the CT scan machine, but going to the hospital and let the clinicians then too now we country understand say these patients you get high blood pressure either because you don't take medication and lead to this or something led to the stroke. Maybe they can get a blood clot and lead to this, but let them address the problem and also do a CAT scan. As we don't already see with the images them way I just show, if you do a CAT scan, you go know now bleeding, or you go know again if not in a clot now cause the stroke. Now because they not be they get enough oxygen, or blood flow to the brain. So if you're able to determine that with the CAT scan, it can really help how you would treat that patient today. Because the recovery to stroke is very long. It's long and patient then can go through so much. So Lord take them very seriously, and this all due to different causes for a patient gets stroke. And this again clinical cause, risk factors, when hypertension, smoking, arteriosclerotic, when if you say somebody get high cholesterol, then get plaque buildup, and also then you get different parts then where the stroke can take place. You get the intracerebral hemorrhage as well as subarachnoid. So these now more in depth for a clinician, for like you get different causes and types them and the risk factors them where they put you at risk for stroke. This not just an algorithm where they use, in the clinic setting, somebody come with, to you with then symptoms and they some of the things that we then go do first, but another thing they want to let you consider, like if you don't do your initial assessment, you don't get the history, don't do the exam, do some testing, you want to find out, consider possible stroke or TIA that mimics, like a seizure or migraine, syncope, like all these different things, the clinicians actually get to go through this for ensure say then really they address the problem we then present with, right? So if any of them questions then they, if not a definite, looking at the possibility or looking at the probability for say this person gets like a mini stroke when a warning sign meaning it can resolve, the stroke can resolve within 24 hours. The one way they go above that now, that person they really don't get stroke. If that stroke they can be, moderate to severe, depending on when they find out, when they present to the clinic setting or to the hospital. And again, not just a continuation. And this now we last slide. This just they try for law we see within the brain they do for we and within are the function on each part of the brain. If we don't mention this during the traumatic brain injury talk, your frontal lobe can deal with your movement, your mood, your intelligence, and your judgment, as well as your logical and decision making, your behavior, your personality, and your planning, as well as the memory with inhibition. So that's not the front part of your brain. So if you see here, the arrow they point to within the brain, these are some of the things that you can really do. And if any part of this if any of them get affected, so now then problem then they get for face, right? And then you talk about the parietal lobe, where they now right here in the middle. It deal with your language, your reading, your coordination, and your sensation, as well as your intelligence and your reasoning skills. And then if you talk about the occipital lobe, when at the back of the brain, and then they deal with vision, as well as, the cerebellum, they deal with your balance, your coordination, your fine muscular control system. And then you talk about your temporal lobe, where be saying at the side of the brain, the two side of the head, but within there, the temporal lobe, you deal with your speech, your behavior, your memory, your emotion, vision, and your hearing. And then within there, you can get your pituitary gland, where they produce or they release hormones there, or they send signal or let the body, that specific hormone them become released, your growth and your fertility. That's not this area with the pituitary gland where you look within the brain. And then your brain stem, it deal with your blood pressure management, your breathing, your heart rate, and your swallowing ability. So this is very important. So you hope say somebody not get a trauma or an injury to this area of the brain. All the other areas are important, but you did talk about somebody in blood pressure, in heart rate, in breathing, and in swallowing ability if there any problem happen to the brain stem. These are some of the references where I go through so that again, if anybody get questions, that's all I have when it comes to these three different topics. Thank you.
We want to say thanks for that. What should we say?
A lot.
Yes, but I believe say it was really necessary.
Okay.
Yes, it was necessary. So now just round up because we're just gonna close. But on my own part, I think say there are areas the way you talk. Say me on I can like for tell me on
Okay. Of course.
We I began for land the hard way. I think it was 2 or 3 years ago. Left go salon because of the hectic journey. The day I wake very late. Not that I didn't have something to prepare for breakfast, but because I've been just reach salon and before they go open some of the stuff they were can don't ship for hand before I go.
Right.
I was so in a mood for going to market. So I left with the posse and then house with me. We're going to market because that day I be hungry for cook potato leaf and cream. And I needed the fresh one. I need the fresh chicken for go buy everything. So we go and not be eat. Mind you, I don't travel all day. The previous day come, even the flight food. I think I bought food from a restaurant. We coming home, but it was not, the hectic and okay. We go market. Then on we way from the market, he said, well, in the market and then be cut the potato leaf. He said, well, let him pass and pick them up. I said, okay, well, me, I go now house.
Right.
From the market to the house, I begin feel dizzy. Okay, I begin feel dizzy, and I made it to the house. I take bike and make I'm not down the junction. Then for go up, say na hill a day.
Right.
I begin claim the hill. I begin claim. Then the symptom begin getting worse. I claim the hill. That was the first time I passed out.
Wow.
I reached now the first like a bakery where they for reach to me. I sit on this small. But I just don't want them to know what's going on with me.
Wow.
So I continue for waka. I sit down there like 10 minutes. I've never done that before. I'm first time I for sit down. I just make like say, because I just come, I just want to say hi to the people. I continue. The last hill for reaching my gate, I couldn't make it anymore. Total blackout. But what I did, I go now the corner part of the gate. There is another empty land where they did. Now there I go lay down. Like inside the bush. But the only two I'll be afraid because I get the house key and I get my wallet, I get other things. I'm thinking to say if possible, I was conscious but not really conscious.
Oh.
Yes. I laid on there for a while till the guy within our house, the caretaker, come. But by the time they come, I don't conscious, but I could not get up. And now the 10, I get up now, go inside house, do the needful, and take a bath, take my medication. Since that day, I think I learned the hard way. Even when I go salon, as I reach, I must go in the kitchen, prepare something, take my medication. Because I find out say I was very, very exhausted. I don't know. But because I not take my medication then, and everything just calm, then it was hot, it was humid, go calm. Notice I not drive now. Okay, now we waka even for going to market, even though the market's not far, it's like 20 minutes, 30 minutes walk. But while they come, I take Okada, then the sun, blackout, and everything was out. Till when the guy come, we meets me corner. If he say no, because I was a car with somebody else, so I was just like, oh, no, I just the rest, and I will don't come, I don't sort out the possible car with. That's the time I tell them. Then at the time now I know say I don't cancel alone. But from that, I not ever risk them. Since that was 3 years ago. Whenever I go now, I know say I gotta sort myself and the medication for day with me. Sometimes I can even buy food for enter the plane because sometimes the plane food knocking all right. And I'm just explaining this so that some other people we maybe you don't. Now me first and dandy for blackout. And imagine a blackout in front of your gate, and I was just lying inside the bush. If possible, can I not for be know that can say food go can't take wallet or take the house in key open, go inside, go take what you want. And it was a scary moment for me. After I counter, I was like, I will never do that again. I will never do that. Even if na a cup of tea, I was supposed to take. I not just feel say I'm okay. But say the other 10 I don't talk say I can do like the entire day I know it. Even I made a skip medication. I usually can skip medication like I go skip medication because if I know it before I know so when I take I go begin for Shiva and all those things. But I think now process learning, even though it began to be the hard way for me and it was scary too. But imagine in Sierra Leone. And I think that was the same time where I get sick, where I began for I'm just later in my trip, I be change my ticket and just fly come back and can take maybe all landing and waiting we just boil up now because all that. But this is just my own. And with you explaining all those things today, I believe say a lot of us see we self inside. And I just hope say we could just continue for take the precautionary measures. I not say now because of the COVID exercise. Like I can always talk like I say me when I go salon, I dey lose weight. Because I go waka, I go up and down. Even though yes I get a car, but mostly for Canada City, make it waka self past the one them waiting at Tongdi. I go park far and waka come or take bike and all those things, you know. But
I think I realized that because I saw you when I just got there, and then before we left, I'm like, you lost weight. I think if you remember, I said that. So
yes.
you do. That is true. I think Africa is good for you. You know.
All right. So we want to say thanks. We really want to say thanks today and for all you do. I believe say through the comments them people they want to say thank you back. So but for today on Aya we go left all thing. We don't spend a lot of time. Thank you for all what you do, and we hope say we go together and teaching how we go to bring we mind them come to we health because we health now in our wealth now human capital. I believe say the one then a salon back go able for benefit because there are some people listening from Sierra Leone go able benefit from this. We just hope say all the intentions we get for Sierra Leone in this kind of teaching we go able then go able grasp and get good out of them. Thank you once more.
You're welcome.
In my own part, you get anything for add there?
Okay, we say number one for say in very in like way then kind of thing they happen. It no matter whether you want like people and see how you day or what's they going with you. get the help right away, because I think, time is very important in when it comes to your health. Can lost people then within seconds, minutes, hours. It all depends. I think you were lucky what happened, but skipping the medication, I know feels in a good thing, just like I be done the talk about, which I would like for always they reiterate to people them, as well as, my patients them, as long as you do check your blood pressure, you can check your blood pressure, and for make sure say you dey within a range way, appropriate. But if your blood pressure dey below 90 over 50, let's say the top part they below 90, and then the bottom part they below 60, I can really see why go want for take your blood pressure then, because the medications then they lower the blood pressure. But at the same time, again, if you dey around, like, let's say 95, 96 over like 60 something, you know, like, you can try for C again and repeat the blood pressure, because we repeat the blood pressure for make sure it's in an accurate number, that just skip the medication knowing that, oh, it's low. And also talk to your clinician to see which in them feel say, when you for skip a dose of a medication compared to when not for take them at all. But again, if it is under that 90 and it is under that 60, it is appropriate for let you take let you hold off on it. Maybe you will take them during the day, for ensure say, you not skip a medication. And if you continue to get low numbers, then definitely reach out to your clinician or your provider. And because sometimes some people then can get hypovolemia, meaning low volume, they're not drinking enough water, all that, they can also affect the blood pressure. And the other thing is stroke. Again, stroke, we already don't see what thing will end up for happen if you get high blood pressure. And if we waiting at some of the reasons, then we people then need oxygenation again. And we think say it's very important, for somebody for like get oxygen, for let them control them blood pressure, as well as, we then know say then get high risk uh, family history, put them at a very high risk. It's important for like the person begin to take all the necessary precautions we can to high blood pressure, we can to stroke, because you get family member we don't get a stroke. So that puts you your risk higher compared to the other person we not get no family history, right? So, and that is something we we will change about yourself. But what you go change now, the things that we you go do when the diet, the lifestyle modification, reducing alcohol consumption can really, really help in how you will manage your health conditions. And also, ask questions if you start on a new medication, if you get side effects, write them down, report them to the clinician, the provider, or the physician, so that they will really help with this. And if you get family members, then we can visit you, your mama, your daddy, then they live with you. Try for make the time, be part of some of them medical appointments. Because with that you get the opportunity for also ask questions, so that because the information, the language, is very different for many people that where they come visit, family members and overseas.
Thank you very much, Doctor.
Yes, you're welcome. Thank you.
Well, that's na Dr. Isatu Kakay-Diallo, and we just believe say we don't try today. I believe say you say one for agree. Say we really don't try today. Eh? So we go left all thing for today. Let's see you, eh? No say me we are ready for talk. I can talk not to so. We are ready for talk, me I can talk. And say na the waiting na the homegrown food, eh? I did tell you, cassava leaf. No, potato leaf and crinkling I be doing with chicken. And waiting can vex myself. And the fall we don't go by and I mark it. Don't work and I don't clean. If so the fall dry. I was also fed and I be did it. It's like for all this so. But it is what it is. We'll go there back tomorrow, eh? I hope say we learn and make we just don't not do like triple away. You get for make certain thing happen before it change how for do things, eh? But we'll go there back tomorrow. Tomorrow we're gonna have a discussion. I not talk it. Not left arm, but tomorrow I get for one. Because you see today we know to politics. You see themselves. But tomorrow you get for one now. I will be there. Eh? Hey. Let me see. I can talk. But till we meet again tomorrow. Triple say. Triple it's still better than the big fat unsweetened chicken we have here. I did tell you. But I see, no, I don't make advertise because me before I can go salad, I might call. I see some people then they do like how we they do, yeah. And they put them in a tray, plastic wrap 'em and everything. The chicken now in a salon and it's homegrown from there, but not to that we local one though. Not to that we local one. Eh? Okay. Till we meet again tomorrow. Triple say, tata.